Well, it's nice to see you all this evening. It's not nice that you've joined us for the second Sickle Cell event that we're doing in partnership with the Sickle Cell Society. We've got two speakers this evening. We've got Claire Samuelson who's already in the room, and we have Brenda that's coming along from the Give Blood Spread Love campaign, and she works for them. So we're going to welcome Claire to speak first, and I'll let her introduce herself and what she's going to speak about. Claire,
hello. Hi, Una. Thank you so much for the invitation, and very nice to meet everyone. I've got a few slides to share, so let me just see if I can figure this out, because as you know, IT is not my strongest point. Right. Can you see this?
Yep, we can indeed. If you go to, there we go. You beat me to it. Perfect.
Right, lovely. So I can't unfortunately see people. I'm sharing the screen, so please do feel free to unmute and just ask questions as we go through. I think it's so much nicer if these things are interactive. But thank you again for having me along. I'm going to talk to you a little bit about sickle cell disease. I'm a haematologist based in Sheffield, where the coordinating centre for sickle cell disease for Yorkshire and the northeast of England. So I also run clinics in Bradford. So they're my West Yorkshire credentials. I'm not sure. It sounds like it's your second event, so I'm sure there's quite a good level of knowledge. So please do tell me if I'm starting from too basic a standpoint. But I thought it'd be useful to talk about what sickle cell disease is, how it's inherited, and some of the treatments that we use for it, including blood transfusion. And I'll come on to why it's so important for people to think about donating blood. So sickle cell disease is caused by a faulty gene. It's a mutation in the beta-globin gene. And we all have two of those genes. We get one from each parent. And that leads to a person with sickle cell disease making sickle hemoglobin, which is HbS, instead of healthy adult hemoglobin, which is HbA. And it means that the red blood cells, which should look like this, nice sort of round, they're biconcave discs, they're quite nice and flexible. When those red blood cells are subjected to stress, such as being short of oxygen or dehydrated, then they turn into these very rigid sickle shapes, like this one here. And that's how the condition got its name, because when we look down the microscope, this is what we can see in the blood of someone with sickle cell disease. And it's these sickle-shaped red blood cells that really cause problems in people with sickle cell disease, because as you can see in this diagram here, rather than flowing nicely through the blood vessels, as these round ones do, they clump up together and they block the blood vessels. Now, if that blood vessel is taking blood to an organ, such as the lungs or the brain or bone or muscle, it means that organ or that tissue is then deprived of blood supply and oxygen, and so it suffers from ischemia, and that tissue can actually die away through lack of oxygen. If that blood vessel is leading away from an organ, such as the spleen in your abdomen, and that's blocked, it means the blood pools in that organ, such as the spleen, and that's called sequestration. So that's the first problem, and that's the one that people think about with sickle cell disease, blocked blood vessels. But increasingly, we're also recognizing that a second problem is also very important, and that's chronic hemolysis, so chronic sort of long-term breaking down of those red blood cells in the system. Because the lifespan of a red blood cell with sickle hemoglobin is so much shorter than a healthy red blood cell. So they just die off all the time in the blood system, and they release some quite toxic components into the circulation. So that leads to the person being anemic because they're breaking down their red blood cells. And also those toxic components can be quite harmful over time as well. So sickle cell disease is a condition that affects the whole body, and this is why it's so severe. It doesn't just cause one thing, it affects every single organ in the body. The most common problem that people come into hospital with if they've got sickle cell disease is an acute painful crisis, and that can be caused called a VOC, a vaso-occlusive or veno-occlusive crisis. It all means the same thing. It means that the blood supply to an organ or tissue has been cut off and compromised, and that can be incredibly painful. I've had patients tell me it's like having your leg broken again and again, you know, if that crisis is in the leg. And it's the same sort of pain, the same character of pain as if someone's having a heart attack. You know, it's that tissue damage, the dying tissue. So that's the most common complication, but that's not at all the only complication that people suffer from. Stroke is much more common in people with sickle cell disease, unfortunately, especially in children. Acute chest syndrome is where the blood supply to the lungs is being cut off, and that can be life-threatening and is one of the major causes of death in children and adults with sickle cell disease. Eye complications can mean that people can suddenly go blind if they've not had regular screening of their eyes and treatment for the new blood vessels. And then all sorts of chronic organ failure. So over time, this condition puts a lot of strain on the heart, the lungs, the liver, the kidneys, you know, everywhere really. And so those organs do tend to fail earlier than they would otherwise have done. It's worth just pointing out here the increased risk of infection, because that's not sort of intuitively obvious, but because people with sickle cell disease generally have lost their spleen by the age of about 5 years, and the spleen is very important in preventing infection, and so that spleen has generally just died off through lack of blood supply. So people are much more at risk of really nasty bacterial infections, particularly young children. So they need to have additional vaccinations and preventative antibiotics. And COVID-19 is very, very risky in people with sickle cell disease. That's a really dangerous combination. So in the UK, as you can see in the top graphic here, most children reach the age of 18 in the UK, which is much better than other countries in sub-Saharan Africa, where most people with sickle cell disease live. Childhood survival is estimated as at 10%, but in reality, it's going to be much, much lower than that, because sadly, most children born with sickle cell disease don't survive to the point where they're diagnosed with sickle cell. So, you know, their death might be put down to infection or malaria or anemia, but actually it was sickle cell disease underlying it. So you can see that with good treatment, survival is much better. But as you can see in this bottom graph, unfortunately, life expectancy is still not normal for people with sickle cell disease, particularly the more severe types. And it's probably averages around 50s. Some people live longer. Unfortunately, some people don't even make that age. So there's still a way to go, and we still need to improve things. Sickle cell disease mainly affects Black people from Africa or Afro-Caribbean origin, and this graph explains why that is. Because being a sickle cell carrier actually provides some degree of protection from dying of malaria, the most severe types of malaria. So this top graph shows you the hotspots for sickle cell in the world. And this bottom graph shows you where malaria is most prevalent. And you can see that, you know, they more or less mirror each other. And it's worth mentioning here, though, that while sickle cell trait or being a carrier does provide a small level of protection against malaria, it's certainly not enough to mean that people don't need anti-malarials. And having sickle cell disease actually means malaria is more dangerous. So, you know, I've had patients who have, you know, haven't been counselled properly about that and have travelled and not taken malarial prophylaxis because they thought they were safe, and that's not the case. There are some people from other regions of the world. So I've got patients from South Asia, the Middle East, South America as well. And in the UK, there are over 15,000 people affected by sickle cell disease and about 1,000 pregnancies per year. Those figures are probably a little higher, actually, because there've not been any very recently figures published. So moving on to the inheritance patterns. It shows how sickle cell disease is inherited. So this baby down here in blue has inherited an abnormal gene from mum, who's a carrier, and an abnormal gene from dad, who's also a carrier. And so this baby is affected by sickle cell disease. And it's worth pointing out that to have sickle cell disease, the most common way of getting that is getting a sickle gene from both parents. But actually, as long as one abnormal gene is the sickle gene, then it's possible to have inherited a different abnormal gene from the other parent. And here are a few of the other combinations that still cause sickle cell disease. So having an S, a sickle gene from one parent, and a hemoglobin C, which is just a different type of abnormal hemoglobin from another parent. That's just a different type of sickle cell disease. Similarly, inheriting the sickle gene with a beta thalassemia gene can cause sickle cell disease. And there's actually a long list of other abnormal hemoglobins that interact with the sickle gene to cause sickle cell disease. If both parents are carriers, then there's 1 in 4 chance that they'll have an affected child, a 2 in 4, 50% chance that they'll have a baby who's a carrier only, so will be healthy, and a 1 in 4 chance that baby will have inherited a normal healthy gene from both parents. And people who are carriers for sickle cell disease may well not know that, because they are, to all intents and purposes, healthy. That's not really a disease condition itself. So when are people screened for carrying sickle cell disease or other abnormal hemoglobin genes? Well, in the UK, we now screen all neonates, and it's this the heel prick test or the Guthrie test that newborns have around day 5 to day 7 of life. The midwife normally does that, and that screens for sickle cell disease and quite a number of other conditions as well. But that's not always been the case. So there will be people who don't know that they're carriers, and they may have moved to the UK from elsewhere as well. Now, we don't routinely offer premarital testing in the UK, but I was speaking to a colleague recently in Nigeria who is a sickle cell specialist as well. And she was telling me that actually the churches and the mosques in Nigeria tend to recommend sickle cell screening before they'll carry out a marriage. And in communities where arranged marriages are more common, that is often taken up. Now, again, I think we need to improve the awareness of preconception screening, because this isn't something that people widely offer. And I will talk to all my patients about it, but if 2 people are carriers, they're not going to be under specialised services. So this is really important people know about this. And I would recommend that couples always get screened to see if they're carrying sickle cell or other abnormal hemoglobin genes, if they're from a region of the world where there's higher prevalence, before starting a family, so that they can then have all the information available to make informed choices about how they want to go forward. And one of the options that should be open to couples if they're both carriers is something called pre-implantation genetic testing. Actually, this is also available if one member of a couple is affected by sickle cell disease and the other's a carrier as well, because they could still have an affected or an unaffected child. So pre-implantation genetic testing, here's a little graphic. It's basically like going through an IVF procedure. There's artificial fertilization of the woman's eggs in the laboratory with a man's sperm. Those embryos can then be tested after a few days to see whether they're affected by sickle cell disease or not, or other genetic conditions. And an unaffected embryo can be selected. So that's a way for a couple to have a child who's biologically there, who's not affected by sickle cell disease, if that's what they wish to do. Of course, there are other options, the donor eggs, donor sperm, adoptions. But the important thing is that a couple's given all of the information that they might need, that they might want, to work out what's going to be best for them. And we also routinely screen antenatally. So the regular screening time points in the UK are neonatal, so newborn screening and testing during pregnancy. So all women in early pregnancy should be seen. They should have some routine blood tests, and they should have a family origin questionnaire. And based on those results, if that woman's in an area with a low prevalence of sickle cell disease, she may or may not qualify to have the detailed screening test. But in areas such as Sheffield with a high risk of sickle cell disease carriage, then all women have the specialised screening test in pregnancy. And if the woman's found to be a carrier, or of course if she's affected, then her partner will be tested. And if he's also a carrier or affected, then they would be offered the option of testing the baby during early pregnancy so that they could decide whether or not to carry on with that pregnancy. So for people with sickle cell disease, prevention is always better than treating crises, which can be terrible to experience and often very dangerous for patients. And all people should be under a specialised centre and should have regular monitoring for complications, because often if we pick things up early before they cause problems, then we can offer additional treatment, prevent progression. Patients, by the time they reach adulthood, they know themselves and their condition very well, and they usually know which things will trigger a crisis for them. For a lot of people, it's becoming cold, it's stress, dehydration, travel is quite a common trigger. And as I mentioned before, people are at risk of more severe infections, so we always advise additional vaccinations, particularly COVID-19, because that's really dangerous in combination with sickle cell. And all children should be on preventative antibiotics. It's a little bit more of a grey zone for adults. The medication that we usually recommend to help prevent complications for people with the severe types of sickle cell is called hydroxycarbamide. If you're in America, you call it hydroxyurea, but it's the same drug. And that's really effective. It works by increasing the level of fetal hemoglobin, which is just a difference of hemoglobin in the blood. And that helps to prevent the sickle hemoglobin from being made and causing problems. And then for some people, it's going to be appropriate to have regular blood transfusions, either a top-up transfusion, which is, like a regular transfusion, hang up the bag of blood and it just drips in through the IV, or an exchange transfusion. And an exchange transfusion means taking out the patient's blood at the same time as giving them healthy donor blood back. We've got a couple of new drugs newly available to us as well. But all of this is managing a chronic condition, because for most people, sickle cell disease is a lifelong condition. The only curative option is a bone marrow transplant, and we tend to only do that for children who've got a matched sibling, which isn't all children, and it tends to only be those with the more severe complications. There are some new genetic therapies on the horizon, genome editing, and that was what my research was in, does offer the possibility of a cure. It's still in trials and not routinely available, but I'm very hopeful that within the next 5 years or maybe sooner, if NICE approves this, then we'll have the option of additional curative therapies. But however good our preventative therapy is, unfortunately, people do still have complications and do still have painful crises and life-threatening complications, and they need to be treated quickly and appropriately, very often in hospital. And I've included a picture here from the front page of a parliamentary group report called No One's Listening. And this was a parliamentary inquiry into failings in sickle cell care across the UK. And, it's very difficult reading. This inquiry was triggered by the death of a young man, Nathan Evans Smith, in a London hospital. He had sickle cell disease and he went in with a painful crisis. He developed a chest crisis, so this really nasty, life-threatening involvement of the lungs, and he was trying to tell the staff looking after him that he couldn't breathe, and as the reports named, no one was listening. And this young man actually called 999 from his hospital bed to ask for help, to tell someone he couldn't breathe, and very sadly he died before he got the right treatment. And what makes it even worse is that that's not an isolated case. And there are many more cases of patients not being listened to, not being believed about their pain, not being given the right treatment for their sickle cell disease. So it's very, very important that we raise awareness as to what this condition is, how awful it is for sufferers and how important it is for people to get the right treatment in a timely manner. So a little bit about blood
Claire, sorry.
Oh, yes.
About the breathing as well, because we think that's how my brother-in-law died, because he was in hospital with a crisis again. He also didn't have a spleen, as you mentioned earlier. He'd not had a spleen for a lot of years, and his sister actually came in the hospital room and found the breathing mask off his face. So
Yeah.
she came in and she let the nurses know, well, you know, you're not checking on him enough, obviously, because I've had to come in and put the mask back on him. And then
Yeah.
it was after that it passed away. And we think it was because of his breathing, because they do suffer with a lot of breathing difficulties. So with you mentioning that, yeah, it just brought that back. But yeah.
Oh, I'm so sorry. That's really tragic, and I'm so
Yeah.
sorry to hear that. It's sadly one of the most common causes
Mm.
of death in people with sickle cell, you know, both children and adults.
Yeah.
But you know, but with the right treatment, you know, often things can be turned around. And I'm so sorry for what your family's been through.
Thanks. But yeah, it just, you know, it highlights obvious the fact that breathing is a major difficulty that they have, you know, because he had to sleep with a mask on at night as well towards
Yeah.
the end of his life. So
Yeah. So both, you know, there's that horrible acute complication, the chest syndrome, but also people, you know, sustain lung damage over time, and you know, the lung function can decline over the years, through the strain and the stress, and you know, the repeated damage. You know, I think that now that we know more about hydroxycarbamide, and you know what a good drug it is, and we're starting children from about 9 months now on hydroxycarbamide. You know, I'm really hopeful that those children who are starting that drug early now, when they come to be adults, you know, they're going to have a different sort of quality of life, because they're not going to have had, or you know, so many years of such severe damage. But unfortunately, a lot of people who are adults now, you know, we didn't have that knowledge, and they weren't on the right treatment as children. So they've already sustained a lot of damage. And then, you know, they can have these recurrent episodes of chest crisis as well, which, you know, it sounds as though your brother-in-law suffered from, and you know, it can become very, very severe very quickly, as I'm sure you know.
yeah, because pneumonia is really common as well, isn't it?
It is. And actually, you know, a big part of my job is educating people in the emergency departments, people on other wards, you know, as to how serious these complications are, and particularly that chest complication, because you know, they might think they're looking at an X-ray and it shows an infection, or they might think it shows, you know, one thing and another, and you know, my job is to tell them it might have started as an infection, and you need to treat for the infection, but please don't ever forget the sickle cell, because that will always be complicating what might have started off as quite a simple infection. So they need to treat the infection, treat any other factors that are going on, but the sickle cell always needs monitoring and treating alongside that as well. So, you know, it's so important that anyone with sickle cell disease who's in hospital, even if it's something that seems unrelated, you know, it might go in with a broken leg or a road traffic accident, you know, it's so important that the specialist team is informed and involved early on, because, you know, it might be the surgeons don't know much about sickle cell disease. They might not know that that individual may require a blood transfusion before surgery. They might not know they're at increased risk of this chest crisis around the time of a surgery or trauma. So, you know, it's important they're educated, not necessarily to be able to deliver all those treatments themselves, but, you know, to have that little flag that goes up to say, anyone that's got sickle cell, you need to call the specialist team straight away. And one thing I'm trying to put in place in Bradford and Sheffield is having an alert on everyone's notes that says, you know, if this person comes into hospital, doesn't matter what they've come in with, you need to call the sickle cell team. It's so important we're involved early on. So thank you for sharing that.
No problem.
Thank you. So we do need to use blood transfusion in quite a few scenarios in sickle cell disease. It's often not an easy decision, because it can come with some complications for the patient, but often there's just no other alternative or no adequate alternative treatment. So in a really nasty acute chest syndrome, or if a patient has a stroke, they absolutely need an emergency exchange transfusion. And then we have patients who are on regular transfusions to try and prevent complications. So, for example, children who are shown to be at high risk of stroke, based on they should have a yearly scan, a little ultrasound scan that looks at the blood vessels in the brain. And if that shows that they're at high risk, then we need to put those children on regular blood transfusions to prevent stroke. Otherwise, the risk of stroke can be up to 20% in a child by the time they get to 18. And other patients who've maybe tried the other treatments and they've just not managed to prevent complications, then they may also need to be on regular blood transfusions. And those regular transfusions, sometimes it's just a normal sort of hang up the bag of blood type transfusion, but very often we use these exchange transfusions. And this young man's having an exchange transfusion, just to show you the machine. So he's got one IV in his arm, has taken his blood out, that goes into the machine, and that removes the sickle cells from his blood and it replaces them with healthy donor blood. So you can see the donor bag of blood up there in the corner. So that's going back into another IV, which is often in the other arm. Looks like he's maybe got them in the same arm. But red blood cells have got lots of different markers on them, and most people know about the ABO blood group. So you might be group A or B or AB or O, but that's just one of very, very many different markers on the red cell, sort of represented by all these little symbols here. And in order to try and prevent people having reactions to blood and making antibodies, recognising the blood as foreign, we try and give as well matched blood as possible to our patients, especially if they've already had complications, already started to make antibodies to donor blood. But it can be really difficult to get very well matched blood. And we've sadly had at least one case in Sheffield of a patient who died because we couldn't find well enough matched blood to give him in time. And he'd previously had severe reactions to blood that wasn't well enough matched. And we know that for most people, the best matched blood is going to be from people of the same ethnic origin as them, because we inherit the markers on our red cells the same way we inherit everything else. But despite that, only 5% of donors are from Black, Asian and minority ethnic backgrounds. So there's a real drive to improve that, because people from South Asia are more likely to have thalassemia and need regular transfusions as well. And there are some rare blood types that are really only found in Black people. So if we've got a patient with one of those really rare blood types who needs a transfusion, they might be in a really very difficult situation if we can't find properly matched blood for them. And then we're left in a situation of thinking, how long do we wait for better matched blood, or do we give what we've got that's not well enough matched, which puts the patient at risk of having a bad reaction to the blood. So it's much better if there's better availability of well matched units of blood. And we do use quite a lot of blood from patients with sickle cell disease across the UK. For adults who are having regular exchange transfusions, they might be having that every 4 weeks. And if for a larger adult, they might be having more than 10 units each time. So, that is a significant number of units each time. And when you think, if you donated blood only lives, it's only fresh and we can only give it for maximum 35 days, but actually we like to give it within about 7 days. If it's for an exchange transfusion, so that the lifespan of those healthy red blood cells will be as long as possible. So we are really very, very reliant on people donating blood regularly. And it's worth mentioning here that anyone with sickle cell trait is very welcome as a blood donor. We wouldn't give their blood to someone with sickle cell disease because it would kind of confuse the measurements, because we like to track how much sickle hemoglobin is in someone's blood. But those units would be very valuable for other patients. And as you may or may not have heard, there's an amber alert out at the moment because of a severe shortage of red blood cell units. So we're being asked to do everything we can to reduce the blood transfusions that we're giving. That doesn't include any sort of withholding transfusions from people with sickle cell disease or thalassemia, because for those patients, there's just no other option. So, they will absolutely still get their regular transfusions, but we're making adjustments to other patient groups, delaying people's surgery, for example, if they might need a transfusion with the surgery. So in summary, sickle cell disease is inherited when a child get a faulty gene from both parents, one of which has to be the sickle cell gene, the other can be another sickle cell gene, or it can be another mutation. But people with sickle cell trait who are carriers themselves are healthy, so may not know that they're carrying that gene. So I think, you know, everyone will have screening for sickle cell during pregnancy, but you know, it may well be helpful for couples to have that sort of information actually before they embark on a pregnancy, so they can be given all the information and all the options open to them. People with sickle cell need to be under a specialist team, need to be seen regularly, need to be on appropriate preventative treatment, and when they do have complications, they need to be taken very seriously and treated quickly. We've got a number of patients who do need regular blood transfusions, but we do struggle getting well-matched blood at times. We need more Black, Asian and minority ethnic donors. So thank you very much for listening. Let me just stop sharing the screen so that I can see people.
Thank you, Claire. That was great, really informative, and everything that we need to know about really in regards to sickle cell and how important the blood donation is as well.
Yeah.
So yeah, thank you very much for your presentation.
Thank you.
Anybody got any questions?
Hi, Claire.
Yeah. Oh, go on then.
Corinne.
Hi, Claire. I'm in Sheffield as well. So I assume you're linked to the Hallamshire?
Yes, yeah, primarily based at the Hallamshire. I do some clinics at the Children's Hospital for the young people coming up to adult services, but mainly at the Hallamshire.
Okay, yeah, because I just sent you a message because I'm doing a bit of work with refugee and asylum seeker ladies that are coming into Sheffield. And I've come across at least one. I've come across another lady, but she's been moved on. But she has sickle cell. She's already been in hospital. And I don't know whether or not these newly arrived people, are they being screened for?
So they're not by all GPs. So I did a teaching session for some of the Sheffield GPs a while ago, and we were talking about this because I think, you know, anyone coming into the country from an area where sickle cell's more frequent, probably is another point that people should be screened, but it's not part of every GP's policy. So very often the first time we hear about someone is when they're into hospital with a crisis. And, you know, bearing in mind the stress of coming to a new country, often, you know, it's much colder in the UK, people may not be prepared for that, dehydration of a flight, etc., does, you know, it's not unusual for someone to end up in hospital within a week or two of arriving in the UK with a sickle crisis. And it would be so much better if we could find out as someone's coming in and, you know, make sure they're getting the right education and support and treatment to try and prevent that. So, you know, any ideas about how we can do that better would be really welcome, and I'd love to hear more about what you're doing with the asylum work.
Yes, I'll put my email in the chat, and yeah, if you email me, then I'll pick up your email, because I work for a mental health charity. We do regular health kind of spots for the wider community. So yeah, hopefully, you know, not everybody knows everything about sickle cell, because we have people who have sickle cell, and yeah, you know, the more information that we all have, far better. You know, you need to come and talk to us and encourage people to give blood and dispel the myths about it, you know, because we have access to quite a wide range of people, and word of mouth really works with us. Yeah.
Thanks, Corinne. Thanks for your question.
That's great, Corinne.
Any others, or shall I dive in with my usual daft questions of the night? But yeah, the transfusions. Oh, go on, Johnny. Do you want to jump in? Oh, you're on mute, Johnny. You're just on mute.
I've asked him to unmute. It's
well,
yeah.
while we're waiting,
You know.
there we go.
Yeah. Right. I said you spoke a lot about the cure, but not about preventing it. What other research has been done? Is it because with Black people or African, the world don't seem to think that when something's wrong with them, we would need to do researches on it.
Yeah.
What effort has been done to it?
So yeah, I can't agree more. I think that research has historically been underfunded for sickle cell disease. And actually the government report that I highlighted calls out institutional racism, and it highlights the fact that services for sickle cell have really lagged behind other conditions. And there's lots of research comparing funding for innovative novel therapies for, say, cystic fibrosis, which is a lung condition, with sickle cell disease. And the money that's invested in sickle cell disease research is about a third of what it is in cystic fibrosis, which very similar in all other ways. It's a sort of life-limiting condition with these acute exacerbations, and it's inherited, and in many other ways it's the same. And so, I think it's well recognised, because sickle cell affects Black people, that it's historically not been researched into as much as it should have been. In terms of the new treatments we've got coming through, I think the genetic therapy, genome editing, is looking most promising. So that's basically taking out a patient's stem cells, and you can just do that through an IV in their arm, taking them to the lab and modifying them, so altering the genetics to help compensate for the sickle cell, and then putting them back into the patient, transplanting them back into the patient. But it's their own stem cells, so it's not like you have to find a donor for them. So that was what I researched into, and thankfully, we are getting these new treatments through. My concern is that although the results from the trial look really positive, really, really positive, I think all of the patients with sickle cell who had this treatment didn't have a single painful crisis, they've only got a few years data, but in the time that they've got following the treatment. My worry is that NICE may not fund it. It remains to be seen. And so, I think the Sickle Cell Society, absolutely needs to be involved in encouraging NICE in the right direction, because, as I'm sure NICE are quite money focused. And my worry is they're going to look at this and they're going to say it costs, I don't know, $1 million, $2 million per treatment, versus hydroxycarbamide, which is really cheap, or blood transfusions, which is much cheaper. But it's not the same, is it? Because this is potentially offering people a cure. Now it's quite new, so we've only got maybe 5 years follow-up data, and we do need to keep collecting data to make sure it is safe in the long term. But I absolutely agree with you. We should be looking for a cure, managing conditions as best we can in the meantime. But in the long run, we want people to have normal lives. We want them to be cured and leave this disease behind them. So I think that is the way forward.
Thanks.
And just, can we, the community, do anything with our MPs and stuff like that to say that this is something that needs doing? Because we want to cure it. Polymyelitis has been cured to a certain extent because they do researches on that, which affects the European. But I'm sure that if enough effort was being put into it, something would have happened where they could cure it before, and not waiting till somebody have it and then try to do the research then.
So you mean kind of cure it before someone's born?
If I can jump in at that point as well, Claire, because that was one of my daft questions. We've had lots of speakers that have spoken about sickle cell, but you mentioned something about the test of a screening process if people are using IVF as a process. Is that part of a way? Is that an automatic thing for people who are having IVF, or is it a choice that parents can make? And if they...
Yeah, so the pre-implantation genetic testing, it wouldn't be, so people having IVF may not automatically be screened. So this is something, people would have to know that they're both carriers, or, if someone's affected by sickle cell and their partner's a carrier of sickle cell or a different abnormal gene. So if they know the babies affected, then they should be eligible, or at least to be considered to be eligible for this pre-implantation genetic testing. They have to still meet most of the same criteria as for IVF. So, in terms of the woman's age and weight, not already having an unaffected child. So there are some kind of reasonably strict criteria. But I think, every couple should at least have the opportunity to discuss that with a geneticist and see if they are eligible, if that's the route they want to go down. A lot of couples maybe, they prefer natural conception, but then have testing in pregnancy. But then if the baby's affected and they choose not to carry on with the pregnancy, that can be quite traumatic. So, the other way allows them to not have to go through all of that and just to pick an embryo that's not affected. So I suppose there's the trauma of going through the IVF, and that does take a bit of a toll. But I think, the important thing is that people are given all that information and they're allowed to make the choice about what's best for them and their family.
Yeah, most definitely. As I said, it's the first time it's been mentioned in his meeting, so we'll look into that further. And the other thing was about blood transfusions. How long does that transfusion process last?
As in hospital, the donating blood.
The admission. So the transfusion, is it a full day to?
So usually it depends. If someone's having an exchange transfusion, that's often a bit quicker than the regular transfusion, and it can be done within maybe 2 to 4 hours, as long as it all goes really smoothly. So if someone's got very good veins and they can easily put the IVs in and they get straight on the machine, it might just be more like half a day. But they'll have had to have gone for a blood test, within 1 to 3 days beforehand, so they can actually test the blood against the donor units and make sure it's all the right type. It can be longer though if someone's got tricky veins, and sometimes, because you do need quite a wide IV to do the exchange, sometimes people have kind of IVs put into their groin and they can be a bit wider, but then often we're waiting, for a surgeon or an anaesthetist to do that. If someone's having those put in every time, they might want to think about having like a longer lasting kind of central device put in, like a portacath, which kind of sits under the skin in the chest. It's like a bit of a button, and you can get special portacaths that you can do exchange transfusions through, but they can be a little bit temperamental. So actually, I'd say being able to get the right tubes, the right lines into someone's vein is often more problematic than and more time consuming than actually the transfusion itself. If people are having more of a regular, hang up the bag of blood type transfusion, normally takes between 2 and 3 hours for each bag of blood to run through, and most people have between 2 and 4 of the blood, just depending on how big they are and how often they're coming. So that can be more of a full day affair.
Yeah. Last question before I bring Linda in, and thanks for the answers so far. Did you say there was an age limit for the transfusions, both minor and older end?
There's a limit for the number of days old that a bag of blood should be. Ideally, we like it to be really fresh. We like it to be within 7 days. For someone having a regular exchange transfusion, 7 to 10 days. If we can't get really well matched blood that's quite so fresh, then we might compromise on the age of those units to get the better matching of the blood. And actually in other countries, they don't have this 7 or 10 day limit. That's more of a UK thing. There's not really very good evidence for it, but it kind of makes sense, right? You think, well, they'll live a bit longer in that person's circulation. So ideally fresher, but we'll compromise on that if we need to.
Okay, thanks, Claire.
Great, thank you.
Linda, if you'd like to
just quickly, I just wanted to ask, with regards to blood types and blood groups, that information isn't readily available. I mean, as far as I'm aware, that GPs don't give out that information in this country. Maybe that should be kind of like a topic or an issue that's brought up with regards to Afro-Caribbean blood types, or people's information, their information about their bloods. Again, educating our people with regards to that information, I think is really important. We don't have enough personal knowledge of our conditions or healthcare within our community. And the other thing I wanted to ask was with regards to, as COVID has had a massive impact, would that affect people donating, whether or not they've had the COVID vaccine? Does that affect donating blood at all?
No, so people wouldn't be stopped from donating, you know, whether they've had COVID vaccine or not. If they've had COVID itself very recently, then there would be a delay to make sure it's completely cleared from the system. And I know they're trying to make sure all the donation centres are very, you know, very clean, very risk-free for people to go along and donate, because understandably, you know, people might feel quite anxious about going into that sort of a setting. And, you know, I'd say if anything, COVID, it's dropped the supplies. It's made people not want to go out and donate, particularly during the height of the pandemic. You know, supplies were low, but actually not quite as low as they are now. I think they're running on, they've only got kind of, I think, 4 days worth of certain blood types at the moment, and they normally like to have much more than that in stock. And it's been partly staff shortages, which again will be partly COVID related. They've had to cancel some donor appointments. So I think it's been a perfect storm really of various reasons as to why there's such a blood shortage. But I agree. I think, you know, education is so important. I think people, you know, if they're interested in their blood type, you know, could definitely get it checked at the GP. They'll probably just do the simple ABO type and the rhesus D type, which is just a few of the markers. And it's the blood donation service that would do the more detailed testing, you know, to see if there's more of a rare blood type that you couldn't tell just from looking at the ABO type.
Thank you.
Thanks,
you.
Thank
Thanks
you.
for your question, Linda.
I was just going to say, you're doing a splendid job, but I hope that we need cure for it, but we also need preventing it. So I hope there is some research sooner or later. How do we come to prevent it rather than just curing it?
Yeah, I agree.
Can I just add? I mean, considering how quickly things moved forward with COVID and COVID vaccines, etc., I think that opened a lot of people's eyes. It opened my eyes. And I think there are massive issues around the fact that somewhere I read some report that 30 years ago, they could have made far better efforts to manage and cure malaria. It could have been done 30 years ago. But like you said, Claire, the will isn't there. And that, you know, just these things, little things like that are really, really damaging to our community. Can I just confirm the age limit for giving blood? Is there an upper age limit?
There's not, for someone who's a regular donor, there's not. People who are maybe thinking about donating for the first time, older individuals, you know, they probably want to make absolutely sure that person's health was very good. But someone who's donating regularly and having no problems whatsoever with the process, you know, they would normally be invited to carry on.
Okay, thanks.
Thank you.
Okay, thanks, Claire. Thanks, Corinne. And Liz, if you want to come in.
Thank you so much, Claire, for a really good summary there, and very insightful as well. I used to work at King's College Hospital in London, and that's something fairly good that London did because of their large population of people from from Africa and the Caribbean. Yeah. Is there's sort of like the screening tests, and sort of that's one of the things that they did in the labs next door to me. But one of the things that we did discover was that the drugs like you said, there's very few drugs, and the Uracil is quite debilitating. It can affect people's joints as well. And there was while I was training, there was a sort of a campaign to sort of try and get different treatment, because it was seen as, well, it's okay if, you know, Black people don't go to work. But I worked with a colleague who was a sickle patient as well as a scientist, and, you know, she had to maintain her family. So she always wanted to, you know, make sure that she was, you know, there was something else out there. So it did inspire us as a sort of scientists to try and do what we could to find better treatments, etc. But like you said, and our colleague Johnny there, was very, very important point you made about the lack of research, and the fact that if it was, you know, sickle cells, very much cystic fibrosis very much more in the Caucasian population, compared to sickle cell. When you look at the vaccine,
sorry, Liz.
for,
I'll push you to ask. All right, okay,
yeah.
I'll push you to ask a question so we can bring.
Just like the vaccine, there was billionaires made out of vaccine and COVID, and there isn't the same sort of money. So I'm really impressed and proud of you, Sister Claire, for doing the research you've done, and as Johnny pointed out, looking for something that will help the community is something that we really need. I mean, NICE didn't consider the price or the cost of the COVID vaccine, so we need to make sure that NICE and the government, you know, think about the cost to us as valid members of this community here and globally. How important it is to have that research and treatment.
Absolutely.
So thank you very much, Sister, for your work.
Okay.
Thank you so much.
If we can give
we're going to bring
we're
going to bring Brenda in now. I'm going to play a video first, and then Brenda's going to come in afterwards, so just bear with me.
Making an appointment is the best way to arrange your donation, as it's easier and will save you time.
Everybody hear that?
Before you give blood, you should eat regular meals, drink plenty of fluids, and avoid any vigorous exercise. We aim to ensure that your whole donation journey lasts no more than 1 hour from your planned arrival time. When you arrive, you should give your completed donor health check questionnaire to the receptionist. You'll be given our welcome leaflet to read, as well as 500 millilitres of water to drink, which will aid your well-being during and after your donation. When your name is called, you'll be taken for your private health screening. You'll be asked some confidential questions, and your haemoglobin levels will be tested. This only takes a moment and is done by taking a small blood sample from your finger. If all is well, after a short wait, you'll be invited to a donation chair. A cuff will be put on your upper arm to maintain a small amount of pressure during your donation, and your arm will be cleaned before the needle is inserted. Your donation will normally take around 5 to 10 minutes to complete. Once you reach the full 470 milliliter donation, the needle will be removed and a sterile dressing will be secured on your arm. We'll also give you a card with some important care advice to take home with you. You'll then be able to go and enjoy the refreshment area, where drinks and snacks are available. You should relax here for at least 15 minutes and have at least 2 drinks to stay properly hydrated. After that, you can book your next donation appointment to keep saving lives with your generosity. Book your appointment to donate. Visit blood.co.uk today. Save a life. Give blood.
Okay, Brenda, if you'd like to come in.
Hi, so I'm Brenda. I'm a volunteer with Sickle Cell Society. I volunteer with the Give Blood, Spread Love project, and my role is to go out and recruit blood donors from the Black community or Black heritage, mixed heritage community. I myself have been a blood donor over 20 odd years. Last week I made my 45th donation, And as a woman, I can only donate 3 times a year maximum. And men can donate 4 times a year. And the reason being that men make up the natural iron quicker than women. And so that's the difference in the number of donations. I originally donated nothing to do with sickle cell. The reason I donated was because my commute in London, I couldn't take the trains and the overcrowding of the trains. And at London Bridge, I saw a van there asking for blood donors. And I thought I'd just kill an hour here until the commute died down at London Bridge. And from that day onwards, I've become a regular donor. Back then, I'm in my 50s now, back then I was in my 20s. And I can only say that I've seen a slight increase of the people coming forward donating that looks like me. Most of the times when I go to a donation session, it is really spot the black. And maybe a few, if I was guessing somebody's nationality, is from Sri Lankan, maybe, or Asian, normally darker Asians coming forward. There are more people, nurses taking the blood that are black, but at the moment, there's only a slight increase when I go to my sessions, and you can tell I'm a Londoner. And, you know, I live in Croydon, a very dense population of black people, and we just don't come forward. My role with the society is to go to places where there are lots of black people, go to the gym, churches, and try to recruit to people to step forward beyond awareness. The actual donation process, I really have to say, is really simple. It really is. People often say they don't want to donate because of they're scared of needles. Well, I think a paper cut stings more than the actual needle. And once it's in, you really don't feel anything. I like to just tell a little story about something that I found was incredible. I was in Brixton Town Hall, one of the donation centres, and there was a young white girl. She couldn't be more than 21. And she was hooked on her phone. She didn't take her eyes off the phone. Yeah, whatever she was doing as social media. So the nurse was there talking to her, checking her name and stuff. And she was just, yeah. And one hand just texting on the phone. And when she, as you can see in the video, you go to a chair and they always double check your name, your date of birth. And she was still on the one hand thing, just on her phone. She made it seem just, this is nothing, just get on with it. Just take the blood for me, yeah? Just get on with it. And I wanted to speak to her, and this was in the middle of COVID, you know, so it was one person in and we were all wearing our masks. The nurses were wearing their masks. And then when we finished donating, I saw her crossing the road and she was still on her phone. Yeah. But what I got from that is it was nothing to her, no big deal. She kept her appointment. Yeah. And she obviously, you know, had her hemoglobin was good and stuff, but it really was no big deal to her. Whatever was on the phone was a bigger deal. Okay. And I'm just saying, for us at the moment, it would be great to have a cure, but we need the community to come forward to be blood donors. We need to go beyond awareness now and into action. And it's really a number game. And I'm sure Claire will explain why it's a number game. If you have 10 people come forward, maybe 2 can't donate for very good reasons. Okay? And signing up is one thing, but booking your appointment, turning up for your appointment, and then passing the finger prick test. You know, so then if you had 10 people and 2 won't turn up, or 2 can't because they've traveled, or they've had a tattoo, or they've had piercings, there's all sorts of things that may delay the reasons why you can't donate. And remember, as far as the NHS is concerned, they have to protect the person who's receiving the blood as much as they got to protect the person donating the blood. So there are processes, and I know that it's open, it can be critiqued, but if we just keep it basic, on a basic level, those are the sort of questions on your health questions. You know, have you recently traveled? Have you had any piercings, acupuncture, tattoos? And these are quite popular things. Yeah, they do happen. But I would say to people, it's a numbers game. So we've got to get people to step forward, to sign up, because I'm here really for people to sign up, yeah, to come forward and say, let me find out if I can be a donor. And then we got to get people to be a regular donor, because I've also come across people when I recruit, they say, oh yes, I've donated. And I said, well, when last did you donate? Oh, 18 months ago. Oh, come on, you're a man, you can donate 4 times a year. Why 18 months ago? And well, I thought I just did my bit. And so we need donators and regular donators for the very reason about how many bags they're needed. And I have another story. I'm in London, and as you can see in the video, what they don't show you now is after you make your donation, maybe 2 or 3 weeks later, you will get a text message, and it will tell you where your blood's gone or what's happened to it. It won't say the individual, but it might say King's College, UCL College, University, Lewisham College, and you've got a good idea that's a black area. It's probably gone to somebody with sickle cell. But one time I donated, and my blood from London went to Birmingham. Why? I was really shocked by that. I couldn't get my head around why is my blood in London having to be couriered up to Birmingham? That means they didn't have enough. And my blood type is B+. I'm not even a RO, which Claire probably could explain better, is a subtype, an even better match from people from the Black community. And the Black community are 54% more likely to have RO, which is a better match than the white or Caucasian community, where it's 2.2%. And that's why we need to come forward. And those who do have RO are prioritized to come forward to give blood. But we won't know unless we come forward. So I know my blood type from the age of in my 20s because I stepped forward to be a blood donor because I couldn't manage the commute. No other reason. And I knew that I was a B positive. Yeah. I also knew if my iron was low or if there was any other problems, because as Claire said, there's a more detailed checking of your blood as a blood donor. The blood donation has developed, it has improved over the years, much slicker, much quicker. You can book your appointment wherever you are, the nearest centre. Some of them are pop-up centres, some of them are blood donation centres. I don't know much about the Midlands, but I'm sure you must have equivalent to what's here in London, as far as blood donation centres are concerned. The upper age to donate for the first time is 66. You can start to donate from the age of 17. But I would really encourage people to step forward now and find out if you can donate blood, and then become a regular blood donor and recruit families and friends. And if you have questions, because I know there are a lot of questions about, well, you know, what are they going to do with my blood? If they're going to clone it, or will it only go to Black people? You know, what happens? No, you can't allocate your blood necessarily to say it will go to a Black person. But then it's not just sickle cell. I know we're on here about sickle cell, but Black people suffer from other things as well. And that could be a great match for them. What I think I'm trying to get across is the NHS shouldn't have to struggle to find the right match, because there's a lack of ethnically or Black heritage blood in the system to match. I mean, the idea of my blood traveling from London, I know it's only up the road, to Birmingham, was just shocking. I know there's Black people in Birmingham.
Yeah,
So,
I agree, Brenda. But yeah.
So I'm thinking, why is that? And that person and their family are waiting. Because during the pandemic, I'll just say this again, when we could go out and do a casual exercise of half an hour, on 3 occasions, I saw bike couriers which said blood service. I'm telling you, those bike couriers broke every speed limit possible in order to get that blood wherever it needed to go. They were not playing. Those there was just going. You just saw the little yellow sign that they have on the front of their motorbikes saying blood service courier. Just wasn't playing. And I just think, if I was a family member or the person wanting to receive it, why am I hanging around? Why can't you find it? Why can't you find the right blood for me? And it's because we need to come forward and become blood donors. Apart from awareness, we need to take action, and it really is a number game. If there's 10 of us come forward, not all 10 of us might be able to donate.
Thank you, Brenda. There's a couple of questions as well, I think, in the chat, as well as a hand up. So we'll go to Abdul first. Good evening, Abdul. How are you?
Evening, Abdul.
Hello.
We can hear you now.
I think I've filled this pop-up form you've actually sent.
Yeah, it was the second one. So there's two polls, one at the start and one at the end. Yeah.
Oh, okay.
A few more questions on the last one. Okay. Did you have a question for Brenda or Claire?
Oh yeah, no, it's just that I was wondering. I've heard about sickle cell, the sickle cell stuff since what, I don't know, the 80s or something like that. And people have been talking about, you know, we should come, you know, Black people should come forward and donate. And we've been talking about this sickle cell business now for so long. I think that there should be some kind of a different kind of approach to it. That if nothing is happening, instead of actually saying for people to come forward, there should be some kind of incentive for them to come forward. Perhaps, I don't know, we should set up a GoFundMe or whatever for sickle cell. So therefore, when people, when we ask people to donate, they should get some kind of incentive. I don't know, say a £10 voucher or whatever, £10 gift voucher for something. But you know, any kind of incentive, like, you know, to encourage people, like, you know, because as it says, since you know, it's been decades, you know, we've been talking about, you know, people, black people coming forward to donate and all this kind of stuff. And it seems as though forever people, you know, there's still a lack of people coming forward. So I think there should be some kind of different approach to it, I think.
I'm not speaking for Claire or Brenda, but I think you're right. If it was a carnival or a family get together, whether it's funeral or wedding, I think we're all able to attend those events. So in a social media age, Abdul, I think you're right. It shouldn't be difficult. I know I've failed to be able to give blood because my veins are too thin, apparently, but that was on the 5th or 6th attempt that I learned that because of not knowing the rules. I didn't have a meal on my first visit. I went at 10 o'clock in the morning and didn't have breakfast, and yeah, just a long list of things that I should have known before I got there. But on the last attempt, when I finally sat in the chair, my veins were too thin. But that points to what Brenda's saying. It needs 10 people to go forward because not everyone, for whatever reason, is going to be able to get it. And I know Yuna's got her experiences of donating as well, which I'll let you share that, Yuna.
Yeah, I donate blood every 16 weeks. And it is an easy process, a very easy process. And when I first went to give blood, the nurse said to me, "Do you know how important your blood type is?" And I said, "All right." She said, "Yeah, for sickle cell especially, because I've got the RO subtype, so it is ethnically matched for sickle cell sufferers. So yeah, it's vital, my blood. So I make sure I go every 16 weeks, and it literally is a 3-minute walk around the corner from my home, and it is such a simple process, you know. And if I didn't do it, I think I'd feel bad now for not doing it, because I know that it is important. And like Brenda mentioned about you getting information back of where your blood's gone, some of my blood's gone to Birmingham as well, and that's when you realize it's gone to somebody with sickle cell, no doubt, that's needed it, you know. And that's how important it is. And we are trying to highlight the fact of blood donation. We've always kept a blood donation information up on our website. It's a constant thing. And we always promote it. Since we launched Pursuit of Happiness, we've always promoted it because it is very close to my heart and to Mark as well. You know, we've got immediate family members that are touched with sickle cell, and we realize how important it is. And now with the, you know, the shortage that is being screamed out there, basically, we're just hoping that more and more of our community is going to go forward and try and give blood. And I say try because obviously there could be an array of reasons why they can't when they get there, but just trying and, you know, and keeping up with that, donating as much as you can. You know, like Brenda's already said, men can donate more than us women, so that's, you know, that's all we can ask for really of our community. And the education and the knowledge is key, and we need to talk about it more, and we need to make it more normal and acceptable about giving blood. So yeah, definitely I would really urge people to consider, you know, trying to give blood.
I just wanted to respond to the idea of an incentive. I think there's an actual policy where the blood transfusion department, they don't want to pay for people coming forward, and their stance is then we might attract the wrong people if you start paying. If you think about it, it's an altruistic sort of thing to do. The fact that your blood can improve or save somebody's life, for me, I've never thought of being paid for donating. I do it for the sheer fact that I know that I'm making a difference. And I think there's lots of people in our community who would do things altruistically, not for any other reason. And I think as a community, we do lots of things without wanting anything back. There's other people volunteer, help their neighbours, even set up what we got here. They do it for wanting to improve other people's lives. They got the skill sets, they got the energy to do it. Now, for me, as I said before, I donated because I wanted to avoid something. I wanted to avoid the crowds, yeah, and sitting. This is before we had social media. Maybe had I had a phone, I probably wouldn't gone and done a donation unless somebody asked me. But because I thought, oh, I could kill time in here and it's warm, and then I found out that I could do it, and it was a simple process. Or why wouldn't I do it if I could help somebody just to ease their life and ease their family's life? And we've all been through certain things where the kindness of strangers have helped us, not people that we actually know personally. I've certainly benefited from the kindness of strangers. And I think the Black community does have people who do things altruistically all the time. I think we can step up and do things. We don't need to be paid.
Yeah, I agree, Brenda, because where would it end? And it just doesn't seem a right thing to do, but that's my opinion.
Yeah, it's true what you're saying there. It's just that I thought the reason of saying that is because it might attract a wider pool of people, like instead of just a narrow pool. Because people actually, because a wider range of people, like this. So if not many people coming forward, then there would be a wider pool of people that might come forward. It's true what you're saying. It might not be the right thing to do. But I mean, is there any choice in them? I don't know. I'm just putting it out there. That's all.
Oh yeah. I mean, I think when I'm recruiting, the sort of things I get that why people don't come forward is a fear of needles. That's a very popular reason. Or it's going to take too long.
I don't have time.
Or I don't have time. Or another reason, people just don't know the process. What happens to my blood? Who is it going to go to? And so that is the awareness of the actual donation process. Also, lots of us travel to certain countries, and if you go to certain countries in Africa, then they would say, well, sorry, you can't donate for another 4 months. Yeah, because you might have malaria or something, and that puts people off. Okay, they think, oh, this is just too long, it's too much of an effort. And yes, you can probably argue those points, but I'm not medically trained. But if that's because they think they want to protect the person receiving it, if I was receiving blood, I obviously would want to be protected as much as I possibly can. And the same with people donating. If your veins are too small, and they say it's too small, or they say you're anemic and you can't donate, then that is only because they needed to protect you. But I also get people say they're anemic and they can't donate. But really, it should be the blood transfusion service that tells you that, rather than an occasion when your hemoglobin just happens to be low at that point, because you can always get it back up and you can go and donate. I think what we really should be targeting is our youngsters, our 17 plus, to come forward. I'm in my 50s now, so we need new blood to come through to regularly donate and get the 1.5% up to 7% of us making up the blood community donation. So that's what we need. We need younger people to sign up.
Well, we do hope in the future, and I can see a name that might be linked to the college, but in the future we will try and make some connections with the college and see.
Well, they used to encourage these things. Schools, secondary schools used to be informed about these things.
Yeah, workplaces used to
the police
encourage.
force, the fire service would regularly give blood. Those big workforces would be given time off to give blood.
I can come in there on that.
It feeds into the rhetoric of, do you know what, just look after yourselves. No, we have to look after each other. It's the right thing to do.
Were you going to add to that, Claire?
Claire?
Oh yeah, I was just going to mention that. I mean, the as Brenda's covered already, I think, you know, one of the reasons they don't pay people for donating and we rely on altruistic donation is it changes the equation a little bit, and it changes the motivation, and it might be that people would be, you know, less inclined to be completely open about answering all the screening questions if it was, you know, if there's monetary value attached. And also, the blood service doesn't now do those big collections where they go into a workplace or a college, because again, people might feel if they're going with a bunch of friends, maybe they don't feel comfortable disclosing a risk factor at that point, and their friends are going to say, well, why aren't you donating? So, you know, I think that was a really useful tool when it was used, but I also think there are good reasons not to do that now and to have changed the strategy a little bit. But it does mean we're so much more reliant on individuals, you know, having that get up and go and go into the centre to donate.
Well, I might be asking the last question of the evening, but the world obviously has got a population of African heritage people. What are other countries doing? Obviously, the African continent has got some very well-established medical facilities in America and other countries. Are we learning lessons from them all the time? And
I think it very much varies based on the country, looking at the different African countries. I did a little bit of work in Cameroon, but I was in quite a rural hospital, but there was no national blood service. And so if a patient came in who needed blood, we were relying on a relative, which is actually, you know, not a great idea. You know, there are additional risks with receiving blood from a relative or the staff. So, you know, I donated a number of times because I'm O-neg, so universal donor, you know, just for people that came in. So, but, you know, we didn't have all kind of the screening and the infrastructure that we have here. And there were people who didn't do as well as they could have done because they didn't get the blood they needed. But, you know, I'm sure in sort of larger capitals, you know, it's probably much better and very different story. In America, I know they pay their blood donors. So it was just a different way of doing it.
Mixed results as well, though, isn't it?
Yeah.
I think the scandals of the past.
Exactly.
Okay. Well, if no one's got any further questions, I really do want to thank both speakers that we've had tonight, because we've definitely learned more than we have done in previous months. I mean, we've learned a hell of a lot more over the past 2 years than we would have done any other way. But thank you very much.
Happiness, I'd love to thank Claire and Brenda for coming on this evening. Thanks for the acceptance of contact for you to come on and spend your Sunday evening with us. So yeah,
thank you. Thank you for having me. It's been a pleasure.
I like to say one more thing.
Go for it.
Until we can find a cure, we need blood donors. And so if you can donate, ask yourself, if you can donate, then sign up. Give blood, spread love. There is a link. If you have any questions, contact us. And if you have anyone in your family or in your circles, spread the word and ask them to sign up. And that is a step forward that you can do now until that cure is found.
Yeah, thank you.
Thanks, Brenda.
Definitely, thank you.